professor at Gyeongbuk National University. Thank you for your kind introduction. So today I'm going to talk about the targeted therapy for breast cancer in systemic medication. So in breast cancer, targeted therapy are a combination of chemo and hormone therapy. But I think that the cost is very high. You have to pay 10 times or 100 times the hormone or chemotherapy cost. So it's a very expensive treatment. From the 20th century, the cancer treatment has advanced significantly. The targeted therapy has been developed, and recently the immunotherapy have developed. In the 1990s, when I have been in training, there wasn't any targeted therapy. So right until here, I have learned and been trained, but then afterwards, these new drugs have appeared. Now, today I would like to cover these things. First is that breast cancer is not a single disease, and I'd like to talk about what targeted therapy are, and then I'd like to introduce what kind of targeted therapies are there for breast cancer, and then I'd like to talk about the limitations and the issues for targeted therapies in Korea. First, breast cancer. If you would like to understand the breast cancer, these are as follows. It's most common among women, and however, the prognosis is good, and it's very toxic. And the targeted therapy and hormonal therapy, radiotherapy, and there are lots of complicated processes are in place, and there are high probability of 5-year recurrence. And also, breast cancer is not a single disease, and if you go to the doctor, then you will listen to a combination of difficult terminologies. So if you look at the microscope, there will be this cell, and it will look like just a single thing. However, there are many things such as HER2 and estrogen receptor, and then PR, and then there are HER2, which is a target. So there are estrogen receptor type, and there are the ER positive, and then there could be HER2 type, and there could be some triple negative breast cancer. So there are largely three types, and there are different prognosis, and the treatment methods are also different between these three types. And we have local treatment and systemic treatment, and local treatment is for the surgery and the radiation, and the systematic treatments are chemo, hormonal therapy, and targeted therapy. So what are the targeted therapy meaning? So let's look at the tumor. It targets the tumor. So there are the gene genetic mutation caused by a carcinogenic factor, and then there will be activation which cannot control the cell cycle. So as we have heard before, a lot of things happen, such as metastasis, and a lot of things happen. And when there is mutation in the cancer cell, it has to be killed at the end of the cycle, but then they find a material which helps them to evade these process, and then they grow into a cancer cell, as we all know. So when there is a cell cycle activation, then the chemo targets that, and then the targeted treatment is there. And then there is a immunology avoidance recovery, then that's what immunomodulation is doing. So in the 20th century, the molecular medicine has developed significantly. So a lot of mechanisms of tumor cells have been found, and the specific molecular features have been found, and targeted therapies have been developed accordingly. So it's different from chemotherapy. It targets specific molecules required for cancer growth. So the adverse events of chemotherapy would not be present, or there will be very little adverse events. And it activates the normal immune system, so the adverse events would not be toxic. And when we say targeted therapy, what would that be? In the 1990s, there was Gleevec, which was developed for bone marrow disease, and which was developed for chronic myeloid leukemia. So in the past, you had to transplant bone marrows. However, that reaches only 50% in terms of cure. And there was a lot of adverse events with that approach. But after the introduction of Gleevec, the 10-year survival has risen to almost 95%. So just like diabetes, cancer could be modulated. And at that time, the Time magazine has introduced Gleevec as the magic bullet. And now it's called targeted therapy. The terminology was recently introduced after the introduction of Gleevec. In breast cancer, therapy and targeted therapy were introduced. And the estrogen receptor combines with the cancer carcinogens, and that causes cancer. In 1980s, the targeted therapy has been already developed, and in the 1990s, tamoxifen has been developed and used, and it was found to be effective. So I say to my patients that tamoxifen is the first targeted therapy in our history. Of course, we do not target the cancer cells directly. However, the signals between the cancer cells would be targeted, and the signals specific to cancer cells are targeted. So it is called the targeted cells in a large sense. And now I'd like to talk about the targeted therapy in breast cancer. There would be different ones depending on the type. First is the standard type. The ER-positive breast cancer has a targeted therapy. For this type of breast cancer, the hormone can be inhibited. The estrogen hormone can be inhibited, and a lot of signals that activates the cancer cells, and those are targeted. And those would be CDK4/6 inhibitor, and then cell cycle activation related PI3K, ALK, and mTOR inhibitors. So if these are used, then it could enhance the existing activation, and these kind of treatments have been developed in the 2000s, and it has triggered massive development of the hormonal treatment. Now we have CDK4/6 inhibitor. In men's, Scully or Verzenio will be the drug, the name of the drugs for these inhibitors, and these were targeting recurrence or the early breast cancer, and the survival rate has been doubled thanks to these inhibitors. And then there is a PI3K medications and agents have been developed, so it could be combined with existing hormonal therapies and raise survival rate to can double the survival rate. So for ER-positive breast cancer, the new targeted therapy can be combined, and that is used as a standard approach, and it is also covered by insurance as well. For CDK4/6 inhibitors, it's not a chemotherapy, but it has similar adverse events. CDK4/6 inhibitors is related to cell cycle activation. So if this is used, the cell cycle activation is blocked. So neutropenia, anemia, and hair loss are occurred, and also some, depending on the specific drugs, you could have different side effects. So you have to consult with your doctor and ask what kind of adverse events can happen with the specific drug that you are applied. And then there are PI3K and AKT inhibitors. This raises blood sugar. So even if you do not have diabetes, then you might have serious diabetes as well. well. And there's mTOR, which is a inhibitor. This causes mucosis, and so you might have to do steroid gargle. Then that can prevent those kind of side effects. And then HER2 overexpressing subtype. For HER2 is a signal antenna, and if this is activated, then the tyrosine kinase would be activated, and this tyrosine kinase activates cancer-related mechanisms. So if there is HER2 expressed breast cancer, then the prognosis is 30% worse than breast cancers in the same stage. So if you have HER2 positive, the patients would be very sad. But then now we have a lot of targeted therapies, so maybe it's better to have HER2 because there are a lot of therapies targeting HER2. There are many drugs that targets HER2 within or outside the cells. You know Septin, which is a drug. Within the cell, the HER2 is blocked. It's a monoclonal antibody drug. So Tirzepatide could be used also. And then with Herceptin, the chemotherapy could be combined. So antibody and cancer drug combination could be used as well. So tyrosine kinase can be suppressed by lapatinib. And then afterwards, the lapatinib effect can be also enhanced by other drug, and the zatucatrib, which reduces the side effects of the other drugs. Now, if you have metastatic breast cancer, the trastuzumab reduces the side effects, and also the survival rate is increased by threefold. And for early breast cancer, the HER2 positive 1 centimeter tumor, the targeted therapies are recommended. And also for tumors less than 1 centimeters, chemo and targeted have to be combined, and that's what's the recommendation these days. And for targeted therapy, antibody are combined, and that's antibody drug conjugate, and that has selective targeted therapy effect, and also it has targeted cancer effects. So these are very strategic drugs that can reduce side effects as well. Now we have Herceptin, which is anti-HER2 monoclonal antibody. The cardiotoxicity is the biggest side effect. When about 2 out of 10 patients had to go through cardiotoxicity, but then there are preventive measures these days. So if you use Herceptin only, and then that's 0.3%. And if you even add the Herceptin, then the probability goes to only 0.7%. The thing is that if you stop using this drug, then all the side effects would go away, so you don't have to worry too much. Now, there have been a lot of medications developed so far, and there are also medications that are already developed but not marketed in Korea yet. So I think with these additional medications, it will benefit our patients as well. Now let's look at the TNBC. Well, TNBC has this name labeled. However, we don't know what it really is. 70% of hormonal positive breast cancer, and then those are endocrine. Those are those, and then 15 to 20% are HER2 positive. So the remaining ones are TNBC. So you cannot target specific aspects. And then if you have BRCA gene, then the damaged gene can be recovered through using PARP inhibitors. So with this, the survival will go up by 2 times. In Korea as well, this inhibitor drug is marketed as well. And another drug is also in line for approval. And in the past, there are immune checkpoint inhibitors which can be also used in breast cancer as well. So Apezovolib and P-Centric or Keytruda could be used. And if it's combined with traditional chemotherapies, then the survival rate goes up by 40%. So if you have progressive breast cancer and if you use targeted therapy at all stages, then that will be beneficial. So it's recommended. So compared to other cancer types, this is recommended for HER2 positive. Even if it's metastasized, the 5-year survival rate would go up. Now, what are the hurdles in using targeted drugs? First, there is a difficulty of finding the target. For TNBC, around 50% of TNBC have not identified its target. And second is that some patients will not respond to the medications, and even they do respond, there will be resistance within their system, and relapse could happen. And then these targeted drugs are supposed to inhibit or suppress cancer. So the drugs have to be medicated for a long time, which means that it will cost a lot. A lot of targeted drugs for breast cancer are covered by insurance, but they are covering just a couple of stages. And for the new drugs, they are not covered by the insurance. And for 1% of breast cancer, which are positive, they cannot use the new targeted medications, which is because of legal barriers. So because of many reasons, targeted drugs are not used. So for those patients, many societies for breast cancer are going through many studies where these clinical trials allow these patients to go through the targeted therapy trials. So I would like to summarize my talk. So targeted drugs and medications are specific to and targeted to specific cancers. It is safe and the side effects are reduced and the efficacy is high, and so it is combined with the existing therapies. In many breast cancers, many targeted therapies are used. So you have to research and consider what kind of targeted therapies you can use, and then consider the next options. Of course, there are side effects for targeted therapies. However, those side effects are more controllable than the side effects for other chemotherapies. So you should talk with your doctor and use these targeted therapies as a preventive measure, and that will be the safe use of targeted therapies. So we have chemotherapy has done a good job until now, but now we have targeted therapy. So the treatment for breast cancer is becoming more and more complete. So it is a good thing that breast cancer has a diverse options for treatment. So with that, I would like to conclude my presentation.